Ευχαριστώ και εγώ ιδιαίτερα. Χαρά μου είναι να συμμετέχω σε αυτό στο αγγλικό τραπέζι. Ευχαριστώ πολύ, κύριε Λιονή, για την πρόσκληση. Με την άδειά σας θα μιλήσω στα αγγλικά. Παρόλο που είμαι Ελληνίδα και ζω στη Κρήτη, η πρώτη μου γλώσσα, η μητρική μου γλώσσα είναι αγγλικά. When we think about the most significant challenges Greece is facing in this year and in the coming year, certainly we could not argue that COVID-19 isn't taking much of our attention and the focus of the healthcare system. Today in my talk, though, I'd like to talk a little bit with you about some of the other very important health challenges facing the healthcare system, public health, and primary care in Greece today. And these are many of the issues that we've known for some time are leading causes and drivers of disease and disability, but also in healthcare utilization and what the cost of the healthcare system is being driven by. And these are chronic conditions, but also infectious diseases and issues of frailty and mental health. All of which are very important and interestingly interconnected with the COVID-19 epidemic when we think of smoking and obesity and existing disease and the underlying cardiometabolic risk factors and how they relate to the experience of someone who is going through COVID-19. So a reality check. The fact is that Greece does have currently today still the highest rate of tobacco use in all European countries. We exceed them in number of people smoking and how much we smoke, and we have the lowest rate of quit attempts in all of Europe as well. When we look at the upward trend in cancer incidence, in particular in lung and trachea, while there is an equivalent decline in all other EU countries, the challenge is apparent. And as we have known for some time, although it is changing, low rates of vaccination relative to other EU countries. We also have at the same time an upward trend in CVD risk factors and high rates of stress, anxiety, and depression. I'm going to focus my talk on health behaviors and in particular modifiable health behaviors as they are significant contributors for many of the challenges that we are facing today, those that I've just talked about. The list is here in front of you, but it's important to recognize that these aren't, if you will, lifestyle choices. These aren't simply practices that people may have. These are health behaviors that are strongly linked to death, morbidity, mortality, and quality of life. And empowerment is a key concept that you're going to hear talked about, I think, in the years to come, and it has been already talked about, but is a concept that we've been working with in our team at the University of Crete and thinking through how within the healthcare system, and in particular in primary care, we can empower patients to take on behavior change and improve their health in so doing, so that it is their decision, their actions, their life that they are taking control of, with the idea of moving behavior change to that of healthier behaviors. And this is very important in recognizing the patient-doctor relationship and the role that plays in empowering patients. We don't tell them just what to do, we empower them with the information they need to make the changes. And in the Clinic of Social and Family Medicine at the University of Crete, we've focused on integrating evidence-based behavior change techniques into routine clinical practice, and very specifically into community settings, but into primary care practice. And we've focused our work over the last couple of years on a couple of different ways of doing that. One is very brief advice. I'll talk about that in a moment, often referred to as the 3A's model: ask, advise, and act. The other is motivational interviewing, a counseling style used for when there is ambivalence or if there is low motivation to engage in a behavior. This is an intervention strategy that's used to address that. And finally, behavior change counseling, where there are techniques that we can use to enhance motivation, confidence, and, if you will, lead to greater success in making changes to health behaviors. There are many models out there and theories, and all of our work at the University of Crete is carefully acknowledging the work of others and the evidence that is out there. We always look very carefully at collaborating and understanding what others before us have done. But one particular model, the Comp-B model, has been guiding our work most recently. And it talks about behaviors being a function of three things: that you must be motivated, so motivation, that you must have the skills and the knowledge to create the behavior change that's necessary, that's referred to as capabilities. And finally, you must have the opportunity. So if you don't have, for example, the ability to get somewhere or pay for something or make the change that you need to, that this would be a deterrent to making the behavior change. So this model guides our work and will be part of my discussion today. I'm going to focus on the example of tobacco use, and a program referred to as the Tighten Greece and Cyprus project, just by way of sharing with you the richness of our work to date and how it may be translated to topics outside of tobacco use, to vaccination, to disease management, and including issues related to COVID. But to stay focused on tobacco use, in Greece, we have 3.5 million tobacco users. It's a huge number. It has declined over the last few years, but remains the leading preventable cause of death and disability. And as I mentioned earlier, is one of the leading drivers of healthcare spending in hospitals, in primary care, and overall. An important public health challenge for us, but equally as important is the role of primary care, pharmacy, and specialty care in addressing cessation with patients. And it's to say that every one of these specialties has an important role to play in motivating patients who walk through their doors to engage in a quit attempt, and for those who are attempting to quit smoking, to make sure you're using the evidence-based practices that we know will lead to quitting in the long term, that they're not using, for example, the advice of a friend or a colleague, but rather what we know works best to quit smoking. We also know that evidence-based interventions are reaching about 1% of smokers in Greece, so a very low number, and that's European statistics. It's quite a bit lower than other countries like the UK, where there's been a big investment in tobacco control. Until recently, as we all know, there had been a lack of political will and health policy to support quitting, to make people more likely to want to quit smoking, and that included smoke-free spaces, which has changed over the last year, and taxation on cigarettes. Most healthcare professionals have not been adequately trained, either in their undergraduate or in their postgraduate training, on how to intervene with smokers. And as such, they lack the confidence. They don't feel they know how to help someone, and certainly they don't know how to do so briefly in the course of a very busy clinical practice. And despite the fact that we have quit smoking medications, if you will, evidence-based therapies for helping people quit smoking, they are not available free of cost. They're not covered under drug coverage, and that can serve as barriers to accessing treatment. A bit about the quitting process, and only very briefly, so that we can understand, and you could apply this information to any topic. But when someone wants to quit, they must first make an attempt to quit. Whether it's successful or not will be determined by a variety of factors, which have to do with how dependent they are, genetic factors, social factors, who smokes in their home, a variety of different issues. And tobacco control policies can influence people's interest or motivation to quit smoking, but also their ability to stay quit. When we think about the healthcare system, brief interventions can help motivate people to quit smoking. And brief interventions would be walking into a physician's office and having them address with you the fact that you're smoking and providing some brief advice about quitting. That can be a very powerful source of motivation. In fact, 30 to 40% of patients will say that they were motivated to quit smoking directly as a result of their physician's advice to quit, and that it ranks much higher than many other interventions with respect to moving people along in their interest with quitting. If someone is going to quit smoking, they of course need to use evidence-based smoking cessation treatments, and you may be motivated, but if you are not using those treatments, you'll have less likely a successful quit attempt. The model we use in clinical settings, the 3 A's model, the very brief advice model that's known internationally, is ask 30 seconds, a very simple question: are you currently smoking? The same question could be used: are you thinking about using the vaccine or being vaccinated? Are you thinking about changing your diet? It can be used for a variety of different conditions. In this case, I'm referring to smoking. 2 minutes is often directed towards, and it can be less or it can be more, a strong piece of advice and guidance around the particular behavior. In this case, it would be strong, personalized, non-judgmental advice to quit smoking and an offer of support with quitting. And then finally, to act, depending on whether someone is ready to quit or not, to spend a few moments of clinical time engaging in, and this would be done at least once a year, supporting a quit attempt with someone who's ready, or delivering a motivational intervention for someone who is not ready to quit. The challenge, of course, is that we're much better in clinical practice about asking and advising. You'll hear most patients say, yes, my doctor asks me all the time if I'm a smoker. He has mentioned I should quit smoking, or he has strongly advised me I should do that, but not as good as intervening and providing support and structure to someone making a quit attempt. There are many barriers to deliver. Motivation of patients and resistance from patients, or concerns about that from the clinical community, is one. As I mentioned earlier, the lack of provider knowledge and skills is, however, another big one. And the place of where some of these behaviors, in this case smoking, but it could be diet, it could be exercise, fit in the context of clinical practice, whether they're important enough to make use of busy clinicians' time. Not being perceived as a priority, and that it's too complicated in a busy practice with time constraints to get involved with. Other challenges that I would be remiss if I didn't highlight is the very addictive nature of tobacco, in particular how it has affected the Greek population. Here's a slide of data collected from one of our projects on the island of Crete. And what it says in a nutshell is that we have a very addicted group of tobacco users who have been smoking for many years, in most cases, 70%, 20 plus years when they're seen in the primary care setting. All of them, for the most part, are smoking a large number of cigarettes today, which will make it more difficult to quit smoking. Many of them have other smokers in the home, and if not, family and friends are smoking, offering that additional barrier or challenge of having social interactions with smokers. So the challenge is not to be underestimated. And likewise, we know that smoking is highly correlated and used at high levels amongst people with mental health illness. And that would be individuals with co-addictions, but also individuals with very serious mental health illness, but also those that we see in day-to-day practice, depression, anxiety, etc. So a very close interrelationship here. Now, the Titan Greece and Cyprus project was undertaken by our team at the University of Crete, but in partnership with medical schools across Greece. This was a pan-Hellenic initiative, in particular the primary care divisions of the university medical schools, and likewise in partnership with the University of Nicosia in Cyprus. These are some of the names of the individuals involved, and they're some of the best and brightest in primary care, but also in tobacco treatment in Greece, and also team members from my group at the University of Ottawa Heart Institute. What we set out to do with this project was to engage primary care physicians, but also the entire primary care team, so nurses and other members of the team, social workers and therapists that work within primary care, and deliver a state-of-the-art one-day training session in the city, face-to-face. We brought the experts in to places like Ioannina, Thessaloniki, and different parts of Crete, and to the island of Kerkyra, during the course of this program. And the intent was to show how in primary care we could deliver evidence-based smoking cessation treatment. And here are some images from the trainings that occurred. You can see they were very well attended from the primary care community. 300 primary care providers were trained, and in addition, 320 medical students that were associated with the universities took part in the training. We were very pleased. It was a very engaging initiative for us. Lots of great feedback on the quality of the program. A toolkit was disseminated alongside the training, and it was to organize in primary care how to deliver an effective intervention, and it included patient self-help materials that could be used in the primary care setting. You'll see on the screen now. One of our challenges was to ensure primary care clinicians were prepared to deal with people who were ready to quit. What do I do when a patient wants to quit smoking? What's the best advice, guidance, and how do I interact with them? But also for the very high number of patients who do not want to quit. And we will see that in other behaviors as well, who are not interested in being vaccinated. Thank you very much, but it's not something I'm going to be looking at now. There's too many reasons why I wouldn't. And that's very true for smoking. How we can effectively intervene with that response from a patient. one of the really important things that we did was make use of motivational interviewing and teach clinicians how to use this particular counseling style, which engages patients to think about and making changes to their own personal behavior, even if it's not something that they're certain about doing. And I won't say more about that, but rather to say that this was very important to the Titan Project, and I think to other behavior changes as well. When there's any form of resistance, we do have strategies that can be very effective in moving patients along and allowing them to engage in thinking about things differently. The Titan Project also produced a series of videos, and you can see on the screen here Professor Lionis and Dr. Anastasίου, who is a part of today's roundtable, in videos with real patients showing how we would intervene, showing the skills that are being taught in real clinical settings. The training was very well received. The high levels of satisfaction is what I'm showing you on the screen right now. We were really happy with this. But more importantly, we saw an improvement in clinicians' confidence, in primary care clinicians' confidence in applying the important behavior change techniques that we know are associated with helping people quit smoking, whether it's using motivational interviewing, prescribing pharmacotherapy, or counseling patients ready to quit. Those were significant differences across the board. And our targets were to improve rates of asking, advising, and assisting patients with addressing tobacco use in the primary care setting. In gray here, you see before the program was implemented, and in red, you see afterwards. And this is probably the highlight of our program. We were able to make direct changes to clinical practice into the, if you will, the influence clinicians were having on their patients with respect to smoking cessation. And we saw significant, but also major increases in rates of treatment delivery. It's a 6% boost in rates of offering assistance with quitting that was documented after only 6 hours of spending time with clinicians and showing them very carefully how they can be more effective in addressing this particular behavior. I'm going to close in a moment or two, but wanted to let you know that during the time of COVID and with respect to behavior change, our team at the University of Crete is continuing to work on the topic of smoking, but the topic of integrating evidence-based behavior change into routine clinical practice. On the screen, you see one of our latest endeavors, which is very brief advice, and turning this into an e-learning, which will be launched just after Christmas of this year. And this particular one is focused on secondhand smoke, το πατρικό κάπνισμα. And again, we show the techniques around very brief advice for secondhand smoke and how it can be addressed for families, for children, for all ages within the primary care setting. We've made similar videos for vaccination and more to come on chronic diseases from our team as well. So in conclusion, when we think about health behavior change, it requires a change in culture within the primary care system, understanding the role, the very important role of primary care and all healthcare professionals in influencing behaviors and how closely they are aligned with the diseases that we're concerned about. Training healthcare professionals in the latest techniques, and in particular in communication techniques and the role of empathy in order that they can be most effective is key. And an integrated plan for health and education. This is one program. This program needs to be re-energized on a regular basis, and likewise looking at undergraduate medical, but also healthcare professional, nurses, midwives, and how we are reaching them to really bring about change with respect to looking at health behavior and public health issues in the primary care and in other settings. So for more information, we do have a website. It's on the screen here for the Titan Project, the one that I referred to at the University of Crete. And I will end with thanking you for your attention, your time.